Hi guys. Okay, so like we said, now we're gonna be talking about signs and symptoms in psychiatry. So these are the signs and symptoms that we expect from a patient for us to say this is a psychiatry patient, not psychotic, but psychiatry. Okay, so these symptoms are grouped into one, speech abnormalities. Speech abnormalities. It's easy to see a patient and say, based on this is an internal medicine patient. Based on these signs and symptoms, this is a gynae patient. Based on these signs and symptoms, this is an obstetric patient. And based on these symptoms, this is an ortho patient, and etc. Not all gynae patients are obstetric patients, and not all obstetrics patients are gynae patients. So I hope you can get that. So what I'm trying to say is we need also to know what features should a patient have in order for us to say this is a psychiatry patient. So we look at the speech abnormalities, we look at behavioral abnormalities, we look at mood and affect abnormalities. We also look at if they've got any psychotic signs and symptoms or psychotic features, if they have anxiety and other related features. So like I said, this is like general. We're not pinpointing any specific disorder here or any specific umbrella. Like I said, we're just being general. We don't need to really know the diagnosis for us to say a patient is internal medicine patient. The fact that they come in with swollen legs, shortness of breath, cough, all that, we might not know the diagnosis, but we can still tell that this is an internal medicine patient. There are few patients that you really need to sit down and really take history, examine, and later on say, oh, it's internal medicine, oh, it's surgery. But majority of the patient, you can sort of like snapshot them. So you can use this to snapshot a patient and say, this is psychiatry. So now, we said speech abnormalities, behavioral abnormalities, mood and affect abnormalities, psychotic features, anxiety and other related features. So now what I'm gonna do is we're gonna delete this and then talk about this. So we're gonna talk about this one by one, and then later on we are gonna talk about mood disorders, talk about psychotic disorders, talk about anxiety disorders, talk about personality disorders, like that. But now we're just being general. Okay, so I'm gonna remove this. So under speech, what are the things that we look at to decide to say, oh, okay, this patient is having a speech abnormality? So they look at the quantity, they look at the rate, they look at the volume, they look at flow or fluency. What else am I leaving? They look at the tone. So there are terms that we need to or phrases that we need to understand here. So when someone has got a speech quantity problem, we can have someone who's got a poverty of speech. So that's a quantity problem, right? So this person who's got a poverty of speech is a person that doesn't want to talk. They answer your open-ended questions with like one-word answer. They like one-word answers or just short phrases. Even when you ask them a question that requires them to explain, they won't explain. They will try to minimize their words as much as possible. That's a poverty of speech. You can also have someone who's got a Logoria. Logoria, this is like an increased speech. This is like a decreased. So Logoria, Ria means an increased flow, right? So this patient is talking a lot, They are talking a lot, and what they are talking about, it's not necessarily that they don't make sense, or doesn't mean that they are talking a lot. It's not necessarily that they are making sense or they are not making sense. What we know at this point is that they are talking a lot. What will decide if they are making sense or not is the speech content. So so let's put it here. So we've spoken about polar speech, Logoria, and now we're also talking. Let me put it in the back actually. So you can have I just want this thing to flow, not necessarily that we should be putting poverty of speech content here, because this is the content problem. It's not a quantity. So let me just not put it here. Let me just put it along. Sorry about this. So poverty of speech content is someone who's talking. They don't have a poverty of speech. They are talking, but as much as they are talking, you are not getting meaningful information from what they are talking about. You are not getting any meaningful information. They are not making sense. They are not getting information. So they've got a content problem. Yes, they are talking. They don't have a problem talking. They are talking to you, and they might not even be logo. They might not even have an increased quantity. They might just be talking, but you are not getting information. So there's a content problem there. They might say a lot of things, but still you don't get information, the information that you want as the clinician. So it's different from a poverty of speech. This one doesn't want to talk. They like yes or no answers, short phrases. even so their answering is not appropriate, because when you ask someone a question that needs to be answered by explaining, then they're not explaining, then that's not appropriate. So it's not appropriate. Yeah, so you can also have pressured speech. So a pressured speech, that would be right now. Someone who's got a someone who's got a poverty of speech, this is common with patients who's got some kind of depression, whatever depression they are having. They don't want to talk, these people. They are retarded. So psychomotor retardation. So yeah, someone who's got a pressured speech. So someone who's got a pressured speech is someone that talks a lot, but the thing is this: you cannot interrupt them. They talk so much that you can't interrupt them. When you ask them a question, they will talk and explain, even though you feel like I have enough information now, but they will keep talking. You can't even interrupt them to show that you want to move on and talk about something else or another question. They cannot be interrupted. So that's a pressured speech. Someone who's got mania, they can have that. And also someone, even Logoria, someone who's got mania. So these are, I'm not saying they cannot happen in another condition, but they are very common with someone who's got mania. This one is common with someone who's got some kind of depression, depressive disorder. And then we also have, we've mentioned pressured speech. We've mentioned, so we've mentioned, and then we've got, okay, let me put this one here while I still remember it. So we can have someone who's monotonous. You know, someone who, if depression can cause this. So when you are monotonous, so someone who's monotonous is someone whom, when they are talking, like as I'm talking to you now, I've got moments where my tone goes up and down. It's sort of like going like that. So it's sort of like going like this as I talk. There are moments where my tone increases and decreases depending what am I trying to explain. But someone who's monotonous, they speak like this, and you can't speak like this. You can't speak like this, because the words that you are uttering should determine your tone. If I'm angry or so it's about expressing your emotion. So when you are just depressed, the only emotion that you are having is a depressed emotion, or you are depressed. So you get that monotonous speech. And then now you've got someone with fluency. You've got someone like who's stammering or stuttering. What else am I leaving? So there are other speech abnormalities which we know from even neurology now. Aphasia, which is an articulation problem, and then we also have dysarthria. And then we also have so with the volume, it can be slow or rapid. This is common in mania. So, and then the last one would be non-spontaneous speech. When you've got a a non-spontaneous speech. This person, they never speak unless you speak to them. And also, when you eventually speak to them, they will answer you. It's okay. They will talk to you. They will explain where they need to explain. But after that, they will keep quiet. They don't ask questions. They answer questions. And they don't start conversations. You are the one who has to start each and every conversation. So that's a non-spontaneous speech. You don't just find them talking, initiating a conversation. I'm not sure if I'm leaving anything, but just to go over this again. So we said that someone we've got a poverty of speech right here. This is a person who does not want to talk. The condition that they have is forcing them not to talk. And they prefer using one-word answers or short phrases. That's a poverty of speech. When you've got a poverty of speech content, you are talking, but there's no meaningful information that can be gathered, or that can be there's no meaningful information that, as much as you're talking, but there's no meaningful information that we can gather from from all that you have been saying and all of that. And then when you've got the pressure of speech, or Logoria is someone who's talking and talking and talking. When you've got the pressure of speech, you are talking, but you cannot be interrupted. And then we spoke about someone who's monotonous, the fluency and the flow, stammering and stuttering. So basically, yes, guys, I know you are gonna go and read this on your own, but this is like just the core, or just the frame of speech abnormalities, and this should be sufficient. So, which means now, that's why I was saying that definitions become very important, because if they give you a scenario, we are doing a paper-based case, they give you a scenario, they will not say the patient has got Logoria. They won't say a patient has got a poverty of speech. They won't say a patient has got a poverty of speech content. You need to read and see, oh, okay, this, based on what they are saying, this patient presented with this is Logoria. Oh, this is monotonous speech, or this is a poverty of speech content. So, and then you tick, okay, I have, maybe when you read that case, you might pick up two points from speech abnormalities, and then as you go down maybe to abnormal behavior, you pick one there, then you go to psychotic features, maybe you pick two there, and then at the end of the day you are able to make a diagnosis, because you did pick up some signs and symptoms of psychiatry in that patient. So guys, I will leave speech abnormalities at this point. You can comment and add, it's okay, it's fine, we are all learning. So yeah, thank you so much, guys.